All right, thank you. So I was given the task of doing thumb pain and 3 topics that cause thumb pain. And these are Dequervain's, CMC arthritis, and Gamekeeper's thumb. So Dequervain's is tenosynovitis of the first dorsal compartment of the wrist. The wrist has 6 dorsal compartments. It has a dorsal retinaculum, and all the extensor tendons of the wrist and fingers are separated into those 6 dorsal compartments. The first dorsal compartment is the one that goes to the thumb. It's the abductor pollicis longus and the extensor pollicis brevis. Dequervain starts with the insidious onset of pain. It's in the radial aspect of the wrist. It's exacerbated with thumb movements, and it usually occurs in the 5th or 6th decade of life. This is not a sports injury per se. It's 6 times more common in women, and the other population that we see it is postpartum women. Physical findings is there's tenderness over the radial styloid, there's swelling over the radial styloid, and there's a positive Finkelstein's test. And you see that those pictures showing the positive Finkelstein's test, and that is put your thumb in, like a baby does, put your thumb in your palm and then have the patient ulnarly deviate. That elicits pain right over the radial styloid. Treatment is usually splinting at first, and then corticosteroid injections in our office. So splinting really doesn't work, but it feels good. It causes them not to ulnarly deviate the wrist, and therefore when they're doing their ADLs, they're not in pain. Corticosteroid injection works. It works about 50% of the time, and that's what we do in the office for patients that are willing. We use 1 cc of celestone, 1 cc of lidocaine. You put it into the first dorsal compartment. You can see it go up the thumb. This is the technique that I use. Other people use different techniques, going proximal to distal, but or distal to proximal. But this, you can feel the tendon sheath fill, and they usually tolerate this injection pretty well, much better than trigger finger injections. The complications of injections, I put this in here just to make sure that we know that, and those are injury to the dorsal sensory branch of the radial nerve, which is very uncommon, and then depigmentation and fat necrosis from steroid injection, which you see a picture of down there, which it occurs occasionally, and when a young woman gets that, she's not very excited about it, and so you have to tell your patients that this could occur. So if that all fails, then you go on to surgery. And surgery is probably one of the most common things that we do in hand surgery. It's one of those bread and butter little surgeries that we do. I probably do a few every week. And this is just a little video that goes through it. It's by the Academy. You can do it under local, and you make an incision over the radial styloid, and you release the first dorsal compartment, And when you release the first dorsal compartment, they don't have pain anymore, because the pain is caused by the increased friction that occurs in that first dorsal compartment with the synovitis. And as those tendons have excursion through that compartment, they get pain. And when you release the compartment, there's no longer that problem with the tendons rubbing up against the side of the compartment, and they get relief of pain. And this is almost universally successful. You put them in a thumb spica splint afterwards. I have them take that thumb spica splint off in 5 days and put a Band-Aid on it, and some of them don't even come back to see me. They're happy. So the next one that I'm going to go over is CMC arthritis. And this also is a big one in my practice and in all hand surgeons' practice. This is the #1 reason for a hand surgeon to operate on the hand for osteoarthritis of the hand. It's arthritis of the trapezial metacarpal joint, or the first CMC joint, also called the basal joint of the thumb. So who gets it? It's women. 10 to 1 or 20 to 1. It's mostly all women. Average age, 50. Whites greater than Asians, and their main complaint is pain. Pain with pinching, pain with trying to open a jar, pain with trying to do anything that requires the thumb, which is about everything you do with your hand. Why do women get it more than men? There's no explanation. So on physical examination of the hand, the patient will come in and they'll say, I have this terrible pain. It's on this side of my wrist. It goes up the arm, and it's been occurring. It's getting worse and worse and worse. And don't tell me you have arthritis, because I won't accept it. So the physical findings, though, are a positive grind. That's the number one thing that we do, and that's where you take the thumb and you just put it through a range of motion, kind of a grinding range, a twisting range of motion, and that really hurts. Conservative treatment for early arthritis is splinting. Thumb post splints are available by the dozens. You can see them on Amazon. We have in our office one that is wraps around the thumb and is made of neoprene because it allows them to be more functional. The use of nonsteroidal anti-inflammatories, arthritis medicine, and injection. And injection is very hard to do. It's not as easy to do as that first dorsal compartment. And so I recommend that if you're not really good at it, you should do it under ultrasonic guidance, because it's easier to find that very thin arthritic joint. Here, this is one of those splints that you can find on Amazon. The therapist can make custom splints if they like. These are rigid splints of the basal joints, so they are encumbering. The advanced arthrosis, though, those that are grade 2, 3, and 4, and I won't go into the grading system here, but there's multiple treatments that you can do. You can do arthrodesis, you can do a trapeziectomy, plus or minus distraction, interposition, which means stuffing something in there, ligamentous reconstruction, and that's forming a sling, and implant arthroplasty. This is one of the first operations that was done back in the late 60s, and it was excision of the trapezium and using a part of the FCR as a suspension and interposition. Now there are multiple ways to do this, and all the people that do implants and the medical supply industry has caught on to this, and they're developing new things all the time to try to get part of this, because we really do a lot of these surgeries. This is just this is Arthrex's tightrope, which works pretty well. And you can see there's the trapezium that is gone. There are a lot of other things that are out there that do interposition. There are these, Artelon was one of them, that was this interposition into the joint to try to get rid of the pain of the arthritis, but this caused a reaction that usually failed within a year. There are multiple implants, just like having a total knee. We're doing an arthroplasty, so you would think, like if you do a total knee or a total hip, that an implant would work pretty good. But the basal joint is a really strange joint. It has just this circumduction range of motion, and the articulation, there is a lot of sliding back and forth between those two, and so none of these have caught on with hand surgeons. There are some that are really trying, but none of them have caught on. The real interest in doing this is to gain better pinch strength in a younger patient to do an implant, but it's not proven really, and it hasn't caught on yet. So this is just a Arthrex showing you how one of their surgeries that they do is kind of that you can do with their implants, and it's similar to what we do, all of us up here, is that we do a sort of suspension arthroplasty, using a piece of the tendon, the abductor pollicis longus, and suspending the first metacarpal to the base of the second metacarpal. And that works pretty well, and there's multiple ways to do it. But the literature says that trapeziectomy is all that matters. As long as you take the trapezium out of there, that you'll get pain relief. And so there is literature from across the pond that says that that's all you really need to do. You don't need all these expensive things. In the United States, you're still going to get a suspension arthroplasty when you go to most hand surgeons, by far. Postoperatively, when you have that done, you have your 2 weeks in a splint. You can tell the patients that they'll have, usually this is our protocol, removable splint after 2 weeks until week 6, then you wean out of it. Usually takes about 3 months to get over a suspension arthroplasty. The last thing is ulnar collateral ligament injury. Now, this is a real sports medicine thing because this usually occurs in sports, okay? It is the injury to the ulnar collateral ligament of the metacarpal phalangeal joint of the thumb. And it's called Gamekeeper's thumb because in jolly old England, they used to have, the gentry used to have gamekeepers, and that's how they killed the game before they ate it, is they just broke their necks. And these guys would come up with these injuries of their thumb. But it can also be called skier's thumb, falling on your hand with a pole in your hand really causes a lot of these injuries in the United States. It's also in multiple sports. You can see it in football. If you catch your thumb on somebody's helmet, it can do that. In biking, if you go over the handlebars and your thumbs are still on the handlebars. In car accidents, if your hand is on the steering wheel and you get pushed forward, it can happen. So there are a lot of different ways of motion. It's all about how the condyles are formed. But it has a lot of strong structures that keep it stable, and it's all about stability. Stability is the key. And when the ulnar collateral ligament goes, you can't pinch, because you pinch, the ulnar collateral ligament has to be intact. So usually we just treat these people in a cast or splint for 6 to 8 weeks, and they get better, unless they have a Stenner lesion. And Stenner lesions are caused by the ligament coming back upon the injury and going behind the adductor aponeurosis and not being able to come down to bone, and therefore no amount of immobilization will allow it to heal. So treatment is operative to make sure there's not a fracture, but hardly ever MRIs. But you can, to look at a Stenner lesion, you usually can tell by palpation and that gross instability. This is the surgery. It's just a small segment of the surgery. It's already open, and you can see the collateral ligament. So you're going through the aponeurosis, and then you can see the collateral ligament underneath it. And then you take a suture anchor usually and place it into the proximal phalanx of the thumb and secure it down. Sometimes the ligament can be destroyed in a number of ways, and it can be torn in the middle, or it can be torn off a bone. And if it's over 8 weeks or 9 weeks, then it's probably not reconstructible because it rolls up into a ball when there's a Stenner lesion, and then you may have to do either a graft or some of the newer techniques that are available for an internal brace. And then postoperative course is immobilization for 6 weeks and a thumb spica splint. And then after that, you come out of it and you have a removable splint for like 4 to 6 weeks. All right, that's it. Thank you very much.